red flag on that. There's supposed to be a big thing on the chart that's like, burp, burp. Okay, it's called a name alert, just to make sure you don't jack it up. You need 2 patient identifiers to make sure you have the right patient, their name and their date of birth. If they are unconscious, what do?
You
check their ID, the
check their
medical
ID
risk.
band. Yeah, you're gonna check their ID band. Make sure you check their allergy band. If they have an allergy, there should be a bright red allergy band. Use name alert and their medical record if 2 patients have the same name. So if you have John Smith and John Smith, you should put a name alert in the chart that will come up when an order comes. And instead of just using their name and date of birth, you also need to use a medical record number just to make sure you got the right John Smith. Clear?
yes.
Sorry.
Yeah.
You check the medical record number, or you make them tell you the medical record number?
Well, they're not going to know their MRN.
That's
So
what I was
their
thinking. They're not
MRN
going to
should
just.
No, it'll be on their band. So you're going to check
their
MRN
band
from the
with the
bar to the
computer.
band. Yes.
Okay, got it.
All right. Number 2 is the right med. So you have to make sure you check the MAR. Then you're going to check your med label. You check the med label and compare it to the MAR. That's your first check, basically. You check the dose, the route, all of that, expiration date, all of those things need to be checked and double checked. Then you're going to compare the label to the ID band, and you should scan the band at the bedside. Okay. Make sure at that time too, you ask about any over-the-counter meds or any herbal meds, and do what's called a medication reconciliation. What is a med reconciliation?
Cross-reference your medications from other sites and hospitals and clinics.
Yeah.
You ask the patient what they're taking and you compare it to what's on the mark. Okay. Yeah. So you're going to say, what are you taking? And then we're going to compare it, because there's sometimes the doctor didn't know that the patient was on a certain medicine, and we have to advocate for the patient and say like, hey, you know, they're taking fish oil at home. Can you write an order for that? Okay. Number 3 is the right dose. Now, if you're getting a med out of the Pyxis, you know what the Pyxis is, I'm assuming.
Yeah.
Okay. 2 nurses have to sign off and use their code. You never give anyone your code, because that is you signing off on something. So if you're busy, you can't say, oh, my code is 4869, just go ahead and use it. Because who's liable for that?
You. Me.
You need to physically be there. Okay. You compare the label to the MAR, and then the MAR to the ID band. You see how many checks we have? You can't mess up. Okay. You have to calculate the correct dose using a safe dosage range. Y'all know what a safe dosage range is?
Yes.
Well, tell it to me.
It's like the range that you give the dosage that's safe for them.
And how do you calculate it?
It's given to you. Like not the.
You have to calculate it, and it's based off of weight.
Yeah.
Okay. So it may say a safe dosage range for this med is between 10 to 20 milligrams per kilo. So you're going to take their kilos. Let's just say they're 100 kilos. All right. So a safe dosage range for that patient would be 1,000 to 2,000 milligrams. Once I calculate that, I'm going to compare it to the range that to the medication the patient's actually getting. So if it says that medicine is ordered on the mark for 3,000 milligrams, I ain't giving it. I'm gonna call the physician and be like, hey, I just want to double check that this is what you want to give, because I calculated the safe dosage range and it's between 1,000 to 2,000 milligrams and you ordered 3,000. Do you understand? You have to do that for every drug you give until you are very comfortable with the dosages.
So are you going to do that every time you go to give the med, or once you call the doctor once you're good?
Wait, what?
Like if you're supposed to give that medicine 3 times during your shift, are you going to call the doctor 3 times during that shift? Or once you call them the first time, you don't have to call them again?
Yeah, once you call them the first time, they should once you call them the first time, they should either say, yes, that's what I want to give. And I would document that. I would document saying, I called the physician to verify the dose. He gave me an order that this is definitely the dose. Like, document that to back yourself up. You don't have to call them every time.
Okay.
Or you may call them and they're like, oh crap, I added an extra 0, sorry. And you're like, okay, you wanted me to murder someone today. Okay. All right.
And then I would have been charged for it.
Yes, for sure. All right. Number 4 is the right route. So you have to compare the MAR to the label. The other thing is to check drug compatibility. You may have 6 meds ordered at 0900. You have to make sure that they're either compatible in the IV site or that they're compatible PO when they're given together. Okay. And it will tell you that in the lexicon too, if they're what they're compatible with and what they're not compatible with. You understand what I mean by that? Okay. Ensure the route is appropriate for the patient. What does that mean?
Like if they're NPO.
And they're like,
Give 'em
take
a
these
PO
17
med.
medications PO. Yes. Or if the patient just had a stroke and they have a hard time swallowing and they're ordered a lot of PO meds, I would call the doctor and be like, we ain't taking this PO. You're gonna have to order it a different way. Okay. So especially if they're like on aspiration precautions or they're in PO, you need to double check. Sometimes they'll let them take medicines PO, even if they're in PO, but it's something you would need to call and double check with the physician for. The right time. All right. So depending on hospital protocol, you usually have between a 30 to 60-minute window to give a medication from when it is ordered or from when it's on the mark. Now, what I will tell you is it is much better for time management when you're a nurse to combine medications together. So you'll have a set of meds that may be ordered at 0800 and another set of meds that are ordered at 0900. So give them all together at 0830 because you have a 30-minute window for each time period, as long as they're compatible. You understand what I mean? Save you a lot of time. Check all the PRN meds. What's a PRN med?
As needed.
As needed, but it has to have an indication, which means the doctor can't just say acetaminophen 1,000 milligrams PRN. PRN what? It would have to say,
Like
yeah,
for
it would have to say PRN for pain greater than 3 out of 10, or for a temperature greater than 100.4. If it does not have an indication, you should not give it. You should call the physician and say, hey, you need to order the indication for this drug. Okay. Know if the medication can be taken with food. That has a lot to do with your timing. Okay. Because if you have 0800 meds due and 0900 meds due and the patient's food doesn't get there until 9:30, then you need to time that correctly depending on if the meds have to be taken on an empty stomach or with food. Do you understand that?
Mm-hmm.
Okay. Check for the time appropriateness. What do I mean by that?
Like, don't give them trazodone.
First thing in the morning.
8 a.m.
Okay.
Don't give them like a
Don't
sleeping
get
medication in the morning.
Sure. Or don't give them like a huge dose of a diuretic at nighttime when you know they're going to be up peeing all night. Okay.
Or a
It can be
stimulant.
changed. You just have to call and let the physician know, like, hey, we ain't doing this. Somebody going to fall. Okay. Document any skipped, missed, or missed meds or time changes. So let's say your patient is due a med at 0900, but they were an MRI at 0900. Then you're just going to document like medication not given, patient in MRI. And then whenever they come back and you do administer it, you put the new time and it should update that in the MAR. So that way you don't have to do it every single time. Okay. It'll update it back to like Q12 or what have you. Number 6 is the right documentation. So make sure you only use approved abbreviations and that you document timely. Because let's say you give a pain med to a patient, you're super busy, right? Patient's like, oh my God, my pain level's 9 out of 10. You give them a pain med and then you're going and like passing meds to all these other people. In the meantime, while you're busy, your patient calls and is like, oh my God, I'm in so much pain still. And another nurse is like, oh, let me just give you a pain med to help out this other nurse because she's busy, but you didn't document that you already gave it. So then she overdoses the patient. You see what I mean? So make sure, especially with medications, that you document very timely. Okay. Number 7 is the right indication. So make sure, and you have to know this before you go in, what med you're giving, why they're getting that medication, what are all the side effects, all the adverse effects, know the onset of action. What does that mean?
How long till it
when they
starts
start
working?
when
It's
it
going
starts
to
working?
start working, and then the duration, which is
How long it lasts?
how long is that going to last? Do you understand? Because a patient or their family, when you go in there to give a medicine, will ask you this. And if you say, they're going to ask for a different nurse. It is your job to know everything about every med you're giving. Because a lot of times you're going to go work in a hospital that is resident run. Okay. If you work in a teaching hospital, they make mistakes all the time because they don't know anything. They're brand new, right? Like, did y'all know that July is the worst time to be in the hospital? That the mortality rate is super high because that's when all the residents come into the hospital.
Yeah.
It is your job to make sure that you check everything that they do. You're going to be correcting things much more than more than they do. As a nurse, you already have your degree, you've already had clinical time. Residents, that is their first clinical time. They've only been in class. They don't know a thing and they're ordering meds on a patient and it's terrifying. So it is your job to know all the things.
Does their mentor doctor not check?
Is there a what?
Like their preceptor doctor, does he not check?
No, they're residents, so they are physicians.
Oh, that's
Ugh. Now, when they do like a history and physical, now the physician will have to go back and sign for it later, but that is not immediate. And if they're doctors, they can write prescriptions. So no, it does not require a preceptor's signature. Okay. Let me tell you, okay, so when Emmy went in, when she was having her spinal surgery, I'd already told them, don't give her morphine because she scratches her face off and she can't sleep. It's miserable. Don't do it. I told the resident that. My daughter was 11 months old when she had that surgery. And guess what this fool ordered?
Morphine.
Morphine pills, PO. I said, you see this baby? Yeah. You just ordered morphine, which I asked you not to, told you she does not do well with it. And then you ordered, like, what? So after he did that, he went home and they couldn't get a hold of him. And I mean, spinal surgery is a really big deal, very painful. So she is screaming and screaming and screaming in pain. I went out there, y'all, I was crying, like mad crying, you know, like that mama bear crying. And I was like, she just had spinal surgery. And I was like, you get her something right now. And this nurse went into the Pyxis, grabbed fentanyl, and she goes, you're a nurse practitioner, you'll know what to look for, and went and shoved it in her IV. And then he went, and I was like, thank you very much. Appreciate you.
Wow.
Yeah, because I mean, y'all gotta watch these residents. I'm not saying there's anything wrong with them. They're just new, right? So they don't know. And once the orders go through, like that's it. You are the last person between this resident and this patient. Are we clear?
Mhm.
Okay. All right. Do we understand the 7 rights?
Mhm.
Yeah.
Yes.
Y'all need a break?
No.
No? Read?
Let's go through with it.
Okay, great. All right, let me see what I want to do next. Okay, we're going to go into the patient bill of rights. Okay, I'm actually not going to read this to you. Y'all can read this on your own. But these are basically, this shit has to be put, I didn't say this shit, just so you know, it sounded like I said that, but I didn't. This should be posted in every, it has to be posted in the clinics, it has to be posted in the hospital, and the patient has to be given this in a pamphlet when they are admitted to the hospital. It is the rights of the patient, and they have a lot of rights. Okay, so this is actually handed to the patient. Okay, like they have the right to be treated with dignity and respect. They have a right to refuse treatment. Okay, so y'all can read through this and see all the different rights that the patient has. I don't need to explain them to you, but what you do need to understand is that they will be, they have to be given to the patient. That's a legal thing. When the patient is admitted to the hospital, they have to be given that. Do we understand?
Yes.
All right. Moving on. Okay. Medication orders. All right. So these are the rules when you get a medication order. All right. Now, you know that doctors can give verbal orders. They can put the order directly into the computer. There's lots of different ways that you can get orders. So you need to know exactly what's involved, because if you give the medication, it is ultimately you. The doctor could write a medication that the patient is allergic to. Okay, they could write the wrong dose. They could write, I mean, there's a million different things that they can do. And will they be held somewhat liable? Maybe, but you know who's held ultimately liable? You, because you gave it. So you need to understand what your rights are for medication orders. So when a doctor writes an order, it has to have all 7 of these things. So it has to have the patient's name and their MRN or their date of birth, the date and the time the order is written, name of the drug, the dosage, the route, how often it's supposed to be administered, and then their signature. So I gave you an example right here. When you get an order that pops up in the computer, it will have the date right here when they ordered it. Now, sometimes, and this is very important, a doctor will order something for the future. Okay. So let's say that they know that they're going into surgery and they're going to go ahead and put in their post-surgical orders. That's why it's so important to look here, because you don't want to give them a med before they go into surgery that is not ordered to be given until after surgery. Do you understand that? So you're going to check the date and the time. The patient's name is here. I should have their date of birth, and you got that. Acetaminophen, so that's the drug. 1,000 milligrams is the route, or 1,000 milligrams is the dose. PO is the route. Every 4 hours is how often we're giving it, or frequency of administration, and then it has to have the signature. You will also see this in the MAR. When do you start it? When do you end it? That is vital. You have to look at every step of that whenever you're giving this. Do you understand?
Yes.
There are sometimes too, I'll just tell you all this for when you go into the hospital, that the doctor orders this and they give an end date. they still want them to get it. It just fell off the mark. So you'll have to call the doctor and say like, hey, I mean, this patient's still puking. I'm sure you still want them to get, you know, antiemetics, or the patient's still in pain, but the order fell off the mark. Can you put a new order in? Do you understand? All right, different roles. The doctor or the nurse practitioner can write the order, okay? Pharmacist, their only job is to prepare it and distribute it. The only time you're gonna choose to call the pharmacist on a nursing school exam, okay, is if you think that they may have sent the wrong medication, not ordered. If there's something wrong with the order, then you call the ordering provider. There are very few times in nursing school you're gonna call the pharmacist, okay? Maybe compatibility issues, like just to ask, is this medicine compatible with this medicine? Or, hey, this medicine got sent up and it doesn't look like the other medicine I got. Can you double check that? But as far as orders or dosages or anything like that goes to the physician or the nurse practitioner. Do you understand?
Yes.
Yeah.
Okay. Which is so funny because it's like doctor and nurse practitioner, their job is to write the order. The pharmacist puts it together and puts it on your unit. Your job is to check for the correct patient, drug, dose, route, timing, allergies, interactions. So ultimately, it is your responsibility. Are we clear?
Yeah.
Yes.
What about phone orders?
Huh?
What about over the phone orders?
You can take phone orders, but if you do, it has to be, you have to write down exactly what they say.
Mm-hmm.
You have to have two nurses verify that. So he or she has to say the order twice to two different people. Then you have to repeat it back to them. Doctors get real fussy on all of these because they want to be like, okay, so let's say you call and say, hey, my patient, you know, I gave him the Tylenol that you ordered, and it's not working, so I need a morphine order. Okay, give him morphine 4 milligrams one time. Okay, am I clear in understanding that you want to give morphine sulfate 4 milligrams IV push ×1 to Donald Jones data? And they're like, oh my God. And then you're like, sir, can you repeat this to this nurse? And then you have to hand over the phone and they repeat it. And then the doctor's like, and you're like, sir, am I understand? And then after that, they have to put it into the computer. Now you can give it if they've just given you a verbal order, but each hospital has a different amount of time at which the order has to be put into the computer. Most of the time it's 4 hours.
I feel like I've definitely seen nurses only listen to it once and write it down, and then that's it.
Yeah, it's not supposed to be that way. It should be done twice from
Okay.
2 different nurses, and you have to repeat it back to make sure you understand what they were saying.
Okay.
Okay.
Got it.
All right. And then there should be 3 checks when you're giving the meds. When you get the med, whether it's the Pyxis or the little drawers or what have you, you compare the med to the MAR. That's your second check. And you do your third check before you give it to the patient. You're comparing the medication and the IV band to the MAR. Do you understand the 3 checks?
Yeah.
Yes.
Okay. Routes. This is just a reminder. I'm assuming y'all know your routes. I don't need to read these to you.
No, I know it.
No.
Like, no, you don't want me to read them, like you understand them?
No, I got it.
You got it. Okay. All right. Just making sure we understand. Okay. The different types of orders. So a standing order means it stays until I've changed it. Okay. So it's like, you know how there are some dudes that are like, I don't say I love you all the time. I told you one time. If it changes, I'll let you know. Sorry, Reem. But you know, like how some dudes are like that. That's what this is like. It's like, hey, I gave you an order. I'll tell you if I change it. Okay. So it's just there. You got a standing order. Single order, obviously, it's one time only. So maybe that's to give a pain med ×1 because they're having pain right now. Okay. If it says to give it now, that means like as soon as it comes up from the pharmacy. If it says to give it stat, that's like you got to call the pharmacy and have them send it up like now. Okay. And then PRN is when the patient needs it. But please remember, when it says PRN, it has to have an indication and you have to document that. So let's say it says give morphine 4 milligrams for pain level greater than 3 out of 10. Okay. Then you would have to document, on top of documenting the mark, you also have to document, like in the notes, patient states pain level is 7 out of 10 in the right knee, pulsating quality. Like you have to do a full pain assessment to rationalize why you chose the PRN medication. You understand that?
Yes.
Okay. If a medication error is made and an incident report is filled out, never document that it has been filled out. Are we clear?
Yes.
Okay, moving on. Let's see. All right, do we understand medication orders?
Yep.
Yes.
Okay. All right. Nursing process when you are giving meds. Look at the pills I drew.
Those are pretty.
Thank you so much. I worked really hard on it. I did a YouTube tutorial on everything. Okay, so in the nursing process, y'all know ADPIE, I'm assuming we got this. Okay. All right, so basically this is the different steps that you're gonna do before you give the medication and after you give the medication for the patient. So before you give any med, okay, you need to make sure you know their history, and then you have to match up what meds you're giving with what you need to assess first. So for instance, if I'm about to give an opioid for pain relief, what would be my assessment?
The pain assessment.
Pain assessment, and what else do I need to do before I give an opioid?
But check their breathing, the rate of
Yes, I'm definitely going to check the respiratory rate because I know opioids decrease that. Opioids decrease their blood pressure, do they not? So I need to check that first, because if their blood pressure is 80/40, am I giving morphine?
no.
Not unless you want to kill a man. All right, so you need to figure out as the nurse what you need to assess before you give that medication. Are we clear on that?
Yes.
D, the diagnose. You have to diagnose with a nursing diagnosis, okay? So that could be if you're giving an anti-anxiety med, you can diagnose anxiety, but that's not actually diagnosing them with a mental illness. That's just what you're treating, right? Or pain or deficient knowledge, whatever it is, you use a nursing diagnosis and make sure it's a NANDA nursing diagnosis.
They're so tedious.
I hate NANDA, but it is what it is. Here we are. All right, the P is for plan. So you need to plan out, what time am I going to give this? Do I need to check and see if they've eaten? Can they take it on an empty stomach? Does it have to be taken with food? Right? And then talk to the patient about admin times. This is important to give them some control over their life in there. If you can, plan with the patient when they're going to take something that is more helpful. Now, some things you can't ask the patient for, like if it's a heart medicine or something, like they got to take it. But if you say like, hey, I know your grandchild's coming up here today. When do you want to take your pain meds so that you're prepared for this visit? Like if the pain meds make him really sleepy and he won't be awake for it, we'll plan it around that. Okay. Discuss ambulation. So before you give a med, you need to plan in your mind, when am I going to get this patient up? Because if I give them massive doses of opioids, are they going to be able to get up?
No.
Okay. If you know you have to ambulate the patient that day, then you need to set that plan in motion before you just give a bunch of pain meds. There's a lot that goes into this, isn't there?
Yeah.
I think like, let me just pass some drugs. You're like, damn, I gotta do 82 steps before I do that. Discuss with them.
Fall asleep.
I know.
Discuss the side effects, adverse effects, and what to expect. That needs to be said to the patient so that they know when you're giving them a drug what to expect. This may make you sleepy, or this may make you jittery, or what have you. Very important. They do this especially like an MRI. Have you ever had an MRI with contrast?
No.
Okay, when you give the contrast IV, it makes the patient flush and it causes severe warmth in the genital area to where people think they are peeing their pants. So if you do not tell them, I'm about to give you this contrast, you're going to feel some warmth in the genital area. It will feel like you're wetting your pants, but I promise you, you are not. It panics the crap out of them. Okay. And the little old ladies will start freaking out. They're like, I'm wetting myself. I'm wetting myself. You're like, no, ma'am, you're not. So it's always better to tell people what to expect. Okay. Rather than have them panic about it. Okay. All right. The implementation, to implement means I'm going to do it now. So I'm going to make sure they don't have to sign a consent form, but you're going to get their verbal consents, right? You don't want to take these meds. Yes. Now, what happens if you go to give the meds to the patient and they're like, I don't want that?
Document it.
Document that.
They refused
Okay,
it.
can y'all do something else first?
You ask why.
Why they don't want it.
Okay, but we don't say why, but yes, in that kind of way, how come you don't want to take this? Nursing just doesn't like why. But yes, you are gonna, like, in that type of way, like, okay, well, what's the reason you don't want to take this? Because yes, we are gonna document that they refused it, but it is our job to try to get them to take it, or to maybe understand the barriers that are preventing them from taking it. Okay. And then if they absolutely still refuse after that, then yes, we can document that they refused it. We need to notify the physician of that, because we may need to do something different. But you always try to like give them more education so that they can take the medication. You have to stay with your patient while they're taking the meds, especially things like potassium. I cannot tell you how many times we get oral potassium is about this big. Okay, it's huge and patients hate taking it. So what they'll do is you'll give it to them in a little cup and they'll be like, okay, thank you, get some juice or whatever. And then you leave and they chunk it in the trash because they don't want to take it. And then you draw their labs again, you're like, dang, we cannot get their potassium level to go up. What is happening? This is so scary. Come to find out, they're just chunking all their meds in the trash. Okay. Or they take their meds and they'll hide it under the bed or something. And then they'll take a whole bunch of opioids later to give them a nice big high. And then you walk in there, the respiratory rate's like 4, and you're like, well, this happened. So you have to stay until they fully take all the meds. Are we clear?
Yeah.
Yes.
Okay. They can give the meds to themselves, but you need to be there. So if they say like, oh, I'll just take these myself. Okay. And then you just watch. Okay. You don't know what people are doing with those meds. And then the implementation is also documenting what you just did. Then you need to know how long those meds take to work. That's why you need to know the onset of action so you can go in and evaluate. Okay. Did the medication do what it was supposed to do? Are they having side effects? Are they having adverse effects? They just took an opioid, so I probably need to recheck blood pressure and respiratory rate. Okay. I need to redo a pain assessment if I gave them pain meds to make sure it's working. And then ask the patient, how you feeling? Right? That's our way of evaluating. Do you understand?
Yes.
Questions on the nursing process?
No.